Now, so that completes our discussion on the basic life support. And of course, advanced life support, once the patient has come to the hospital, mostly examiners don't ask you. This is the emergency treatment that is required, and what are all the IC management, and what are all the various drugs that are given to stabilize the cardiovascular system. All that becomes a routine ICU management. So these three things you have to remember. One is the adult cardiac arrest or algorithm, and advanced management post resuscitation for adults and children, and pediatric this thing, mainly because of the differences in the rate of respiration, cycle time, and the drug dosages. That is the main difference. Okay. So if you have any doubts on that, we will discuss it at the end of the class. Now going on to the drugs which are commonly asked in the anesthesia viva. There are plenty of drugs. Now, I have classified it according to the second Hill book of pharmacology used by the fellowship students in UK, and this book is only mainly followed by dependent curriculum also. So I have taken the list of drugs that are there. These are all the names that you should know. So general anesthetic agents, commonly earlier we were using tipentone, which was a barbiturate drug very commonly, and there was another drug also called methotrexate. Many of you would not have even seen this. It has now completely become obsolete. But examiners, if they ask you what are all the barbiturate derivatives, still some hospitals may be using tipentone, but methotrexate was there during our PG period, which is not there now. And non-barbiturate drugs used for induction are propofol, ketamine, etomidate, and inhaled anesthetics. So these are all four still in practice. So you must know something about all these drugs. And because of want of time, I'm not going to individually discuss, but some out of the box thinking questions I'm going to ask you later on. And second group of drugs you should be aware of are the analgesics, which are opioid and the related drugs like morphine, diamorphine, codeine, dihydrocodeine. Fentanyl is a drug which you are using day in and day out. So you must know everything about fentanyl. What are the So any drug, when it is given in the exam to you, first read the name of the drug in the label. Don't as soon as you do it see it from a distance, don't start answering. Take the drug in your hand, go through the label, see the composition, see the date of manufacture and expiry also. Some examiners are very fond of finding out whether you are a safe anesthetist, whether you see the manufacturing date and expiry date and not using a drug which is out of its life. So read out that also. That will give a better impression that you are a safe anesthetist. So, after reading the name of the brand name, then the generic name, and if it is a vial containing multiple components, you read all the contents with each ml containing so many milligram, everything, and then finally read the date of manufacture expiry. Okay, and then go on to say which class it belongs to, whether it is an induction agent, whether it's a muscle relaxant, whether it's an analgesic. And then if they ask you further about the pharmacology, then you can talk about all those things. So that is the way you go about, and the drug is given to you in your hand. And tramadol is another common drug which you are using day in and out. And so be well prepared with the fentanyl and tramadol. And some of you may be using pethidine, and morphine is another drug which is very commonly available. So you must know everything about morphine, all about opioid receptors, the various types, what is the mechanism of action, everything you should read before you go for your exam. And these the pentazocine, buprenorphine, and nalbuphine, they are called partial agonist antagonists. So Some hospitals still use these drugs. Buprenorphine, of course, is available in many hospitals, but pentazocine and nalbuphine, I don't know whether many hospitals are still using or not. And NSAIDs we are using regularly both for intra-op and post-op analgesia, especially diclofenac is available as an IV preparation also. And paracetamol, we should know everything about paracetamol because we are routinely using this as a 1 gram preparation available as an IV infusion. So we must know everything about paracetamol. What is the mechanism of action of paracetamol? Here and there I will ask you some important questions about it. What is the mechanism of action of paracetamol?
COX inhibitors.
Cost
Not
inhibitors.
selective COX inhibitors.
That's the only method. What does this COX inhibition do? Cyclooxygenase inhibition. Where does it inhibit? Which exact location of our body the COX enzyme is inhibited by paracetamol?
Cell
Membrane.
membrane we have
Perimembrane.
is
Which perimembrane? Which perimembrane of which organ? It is in the hypothalamus. Okay? Prostaglandin action on hypothalamus is one which is affected by paracetamol. That is the mechanism by which it produces both analgesia and antipyretic effect. Okay? So this COX inhibition occurs at the hypothalamic level by decreasing the production of prostaglandin. Okay? That is the mechanism. And of course, paracetamol, they can ask you about toxicity also. Paracetamol overdose. What is the toxic dose for an adult for paracetamol? Because this is a drug which is available over the counter. How much grams or milligrams of the drug a person should take to get a toxicity?
7 grams are in
4
adults.
grams per day.
12 grams. 12 grams for a 70 kg adult is the toxic dose. Okay. Normally we give 0.5 to 0.65 grams or the 650 milligram 3 to 4 times a day. That is the maximum we give. Isn't it? And if it is given intravenous, we give 1 gram twice a day or 3 times a day maximum. So maximum we don't exceed 3 to 4 grams per day. But 12 grams is the toxic dose. What will happen if a person ingests 12 grams of paracetamol all at a time? What is the major problem that can happen because of overdose of paracetamol?
Toxic illness.
Acute liver failure.
Metabolic.
Answer is acute liver failure. And that acute liver failure answer may lead to what is King's College criteria for liver transplant in a patient with paracetamol overdosage. In UK, they have formulated because in UK this is the most common drug which is available, and people wanting to commit suicide or kill themselves, they take overdosage of paracetamol and land up with acute liver failure. And King's College London is the center worldwide known as the first center to do liver transplantation successfully. So they have formulated a guideline based on the pH, the albumin and other things of the liver. So read about King's College criteria for indications for acute liver transplantation. Okay. Then coming to local anesthetics, how are local anesthetics classified?
Amino ester.
Amide and ester.
Amide linked or ester linked. Okay, this is here I have written here amide linked local anesthetics, ester linked local anesthetics. Examples of amide linked are lidocaine, bupivacaine, levobupivacaine. What is question about levobupivacaine? Why levobupivacaine has been introduced instead of bupivacaine now?
Decrease cardiac toxicity.
They reduce cardiac toxicity and the easy resuscitation even in case of overdosage. Okay. Earlier, bupivacaine overdosage caused very resistant cardiac arrest. So the drug would not separate from the sodium channels in the myocytes. So it was very difficult to revive the heart. whereas levobupivacaine is less cardiotoxic. What is toxicity ratio of a local anesthetic?
3.5 for bupivacaine, CCCNS ratio, and lignocaine 7 mg.
So toxicity ratio, if they ask you numbers, you can say that. But if what is the definition of toxicity ratio? It is
CNS to
Amount of the
CNS by
required
CVS.
serious complication. Very good. So what are the advantages and disadvantages of bupivacaine, which is also used very commonly in India?
provide sensory blockade.
Lesser motor blockade.
it's a
Or
motor
less-
blockade, so it is actually
less
lesser
effective.
motor blockade, so
Stable
more
answer.
useful for ambulatory or selective sensory blockade alone, and less cardiotoxic again, like levobupivacaine. Okay, and available in various concentrations. Compared to levobupivacaine, this is available in concentrations of 0.2, 0.3, 0.5. Okay, various concentrations are available. What is the one notorious complication of prilocaine?
Hemoglobinemia.
Methemoglobinemia.
Methemoglobinemia. What do you understand by methemoglobinemia?
So there's a conversion of
Happens in
autoleukin in the liver.
Huh?
The prilocaine produces a autoleukin after conversion in the liver to produce methemoglobin.
No. My question is, what do you understand by methemoglobinemia? What happens in methemoglobinemia? What way the hemoglobin is affected? The iron content.
Iron is
Normally, in which form it should
we
be
should
to
not
take
carry
the
oxygen.
It should be in ferrous form,
Ferric form.
Fe2. Okay, but in methemoglobinemia, it gets converted to ferric form, Fe3 plus. Okay, so it cannot carry oxygen. Okay, it will produce hypoxemia, tissue hypoxemia. Okay, how do you correct that methemoglobinemia?
So
How do you
methylene
do
blue.
Methylene blue.
Methylene blue, how
Vitamin
much?
C.
How much? What is the dose? You are right.
1
Both
mg
the
per
drugs
kg,
can
sir.
1 mg per kg.
Per
1
kg IV.
mg per kg IV slowly over 15 minutes. Okay, and vitamin C 500 milligram in 100 ml of saline over 20 to 30 minutes. Okay, these are the doses also. Right. Ester link we have earlier cocaine. Who introduced cocaine to clinical practice?
August
History.
period. Just
Not August Bayer. It's Karl Proller. K-A-R-L Proller. Karl
Ophthalmics.
Proller was a person. Okay. So suddenly history question also may come. Karl Proller may be but before whom? Before Karl Proller, who was using cocaine? He was not an anesthetist. Karl Proller also is not an anesthetist. Which specialty he belonged to? He was an ophthalmologist. Karl Proller was an ophthalmologist, but he was working under Sigmund Freud, who was a psychiatrist. And Sigmund Freud was doing a research on cocaine addiction. So he used to bring the coca leaves and then chew them and find out that the effect of cocaine. And Karl Proller, when he was chewing it, one drop of his saliva with the cocaine fell on a patient's cornea. The patient did not feel anything when he wanted to test the intraocular pressure. So that is how we found out that it causes a blockage of sensation and introduced it in clinical practice. And sometimes with the cocaine, they may ask you about Moffett solution, MOFFETS. I think I have showed it in my earlier lectures in the slides.
Sir, for low
Moffett solution.
anesthetics,
For
anesthetics and
vasoconstriction.
airway, sir.
Vasoconstriction. It was a combination of cocaine, sodium bicarbonate, and adrenaline. All three mixed together and diluted with saline and used for ENT procedures. Okay, introduced by a doctor called Moffett, who was an ENT surgeon. So that is called Moffett solution, containing. Then the other rare drug which we are now sometimes using is chloroprocaine, ester-linked. Why ester-linked local anesthetics are not very popular compared to the amide group of drugs? Why ester group of drugs are not very popular?
Chance of
less shelf life. They don't stay with potency for a long life. Their shelf life is very, very short. Okay. So that is the reason. Whereas when you can store amide local anesthetics for 3 years, 4 years, whereas the ester group drugs, they lose their potency within 6 months to 1 year. So it is not profitable to manufacture and keep this. And what is the advantage of using chloroprocaine? Where is it commonly used? In daycare procedures, because it is a very, very short acting local anesthetic agent. Even when you administer it in spinal anesthesia, a patient will recover within 25 to 30 minutes. So for some bottom surgeries like incision of a perianal abscess or doing a piles ligation or small procedures which can be completed within 30 to 30 minutes, you can use chloroprocaine intrathecally and patient can walk back home within 1 to 2 hours time. So after it, and he will recover, of course, all the sensations within 20 to 30 minutes. And where is amitocaine used? Amitocaine is also a ester linked and it is used as a lozenges for local anesthesia during airway management to anesthetize the throat and the glossopharyngeal nerve. It is available as lozenges like your Vicks, Halls, like that. And the patient can just suck it in the mouth and the whole oral cavity and pharyngeal cavity will become anesthetized. So with regard to local anesthetic, you should always be prepared to answer all questions on intralipid. What is the role of intralipid?
Removal of local anesthetic
Used
from
mainly in
cells.
bupivacaine toxicity, okay, to remove the drug. So intralipid dosage, any idea about
1.5
intralipid dosage?
1.5 ml per kg to be given over 1 minute, followed by
Yeah. So remember the dosage. Please read and remember it well before you go. And was it introduced as an antidote for bupivacaine toxicity? What is the original use of intralipid?
nutrition,
Parental nutrition, sir.
In total parenteral nutrition, it supplied the lipid component. Okay. Then you must know everything about eutectic mixture. What is the name that you commercially use?
Emla cream.
Emla cream. Eutectic mixture of local anesthetic. What is the composition of eutectic mixture?
2.5
Pilocaine and
Pilocaine and xylocaine, equal volumes. So what happens when you mix these two agents like this?
lower the melting point of the area to
Very
melting
good.
point
And
decreases.
eat them in a cream form. Okay, very good. And you must know about local anesthetic systemic toxicity and hemoglobinemia. All these things we have already discussed in the various classes. Then the next group is muscle relaxants. And muscle relaxants, common depolarizing is succinylcholine. Can you tell me how succinylcholine is metabolized in the body? Pseudocholinesterase. Plasma cholinesterase or true cholinesterase?
plasma cholinesterase.
Plasma, yes.
Pseudocholinesterase
Pseudocholinesterase
of
or
tissue
plasma cholinesterase is the one. What are the steps in the metabolism of this drug or degradation?
Phase 1.
Phase 1, phase 2. Phase 1, phase 2 is the block characteristic. Metabolism or degradation, it is actually succinyl dicholine. It is nothing but a combination of two acetylcholine molecules. The structure of succinylcholine is nothing but combination of two acetylcholine molecules. So it is first broken down into succinyl monocholine. And then the second step, this is called rapid hydrolysis. After this hydrolysis and breaking it from succinyl dicholine to monocholine, there is a slow hydrolysis where it will be broken down to succinic acid and choline. So there are two steps in the breakdown of succinylcholine that you should know, and you should know all the side effects of succinylcholine. Why people nowadays do not prefer to use succinylcholine unless it is what is the only indication for usage of succinylcholine?
Rapid sequence induction.
Rapid sequence induction. Excellent. So all other things What are all the? Can you name a few side effects or complications of the usage of succinylmetonium?
Most common is
Hyperkalemia,
myalgia,
Myalgia,
malignant hyperthermia,
malignant hyperthermia, apnea, all
increased
these. So these are
IOP.
all the side effects you must be knowing. MH, that's apnea, and then they may ask all questions on neuromuscular monitoring. How will you find the train of 4 after succinylmetonium? How will you find the train of 4 after atracurium or cistracurium? Okay. So the classification of muscle relaxants. How can you classify the muscle relaxants?
based on the duration of action, based on the structural component, and
Depolarizing
based on depolarizing and not depolarizing agents.
Mechanism of action. Very good. So these are all the things. So aminosteroids, example, mecuronium, rocuronium, pancuronium. Then benzyl isopurinolenium compound, atracurium, cistracurium, mevancurium. What is the peculiarity of mevancurium?
plasma
Is it
cholinesterase,
metabolized by plasma
enzymatic
cholinesterase?
degradation.
Shortest acting muscle relaxant. Okay. Which is the longest acting muscle relaxant?
Pancuronium,
Pancuronium. Intermediate?
mecuronium, atracurium.
Atracurium and cistracurium. Okay, right. Okay. And reversal agents, you must know everything about neostigmine, sugammadex, and about myasthenia gravis. So, how much of neostigmine you will require for myasthenia gravis? What are the features of myasthenia gravis? How is it different from Eaton-Lambert syndrome? Okay, these are the common questions they may ask you on these reversal agents. Then comes the sympathomimetics. How do you classify the sympathomimetic drugs? The answer is here, naturally occurring and synthetic. Okay, so you must know all about adrenaline, noradrenaline, dopamine. Similarly, synthetic you must know about alpha agonists like phenylephrine, beta agonists like isoprenaline, dopexamine, salbutamol, salmeterol, ritotrine, and mixed alpha and beta drugs like ephedrine and metrabenol, and other non-selective phosphodiesterase inhibitors like aminophylline, selective phosphodiesterase inhibitors like enoximone, milrinone, glucagon, calcium, and even T3 is considered as a sympathomimetic drug. So please read about all these things, and of course most of you will be knowing all about adrenaline, noradrenaline, dopamine, which are regularly used. Okay? And phenylephrine also you are well versed in day-to-day usage. And the next category of drug is adrenaline antagonist. So there can be what is the use for phenoxybenzamine?
Pheochromocytoma.
Pheochromocytoma. Okay. So first always start with a alpha blocker, then go for beta blocker. Don't start with the beta blocker. And selective alpha 1, prazosin and doxazosin. Where do you use this?
Benign prostate hypertrophy.
Very good. Excellent. Renal prostatic hypertrophy as a medical management. Alpha 2 inhibitor is yohimbine. What is the use for yohimbine?
It's a reversal
Reversal. Okay. Google and let me know before the end of the class. Beta adrenergic antagonist, non-selective. Propranolol. What are all the indications for usage of propranolol?
thyroid crisis.
Thyroid crisis or on a regular basis for hyperthyroidism. Patients who are being treated not only with anti-thyroid drug but also propranolol for
Anxiety,
peripheral conversion of T4 to T3. That is the main reason why we use it in hyperthyroid patients. What are the other non-thyroid indications of propranolol?
Anxiety disorder.
Anxiety disorder, tremors, okay, and migraine. All these things are non-cardiac indications for usage of propranolol. And cardioselective or atenolol, esmolol you must know inside out because that is a drug which you are routinely using in most of your practice. What is the most important indication for use of esmolol in your day-to-day practice?
Say ultrashort
To attenuate intubation response.
Attenuating the intubation response. Excellent. What is the indication for metoprolol?
It
Theracid mainly used.
Tachycardia.
Prophylaxis of
Yes, cardiac selective mainly for post-ischemic heart disease patients.
issues.
Okay, many of your ischemic heart disease patients will be on metoprolol. And labetalol, it's a combination of both alpha and beta antagonist, and the major use of labetalol in
Hypertensive disorders of pregnancy.
Pregnancy is
preeclampsia. Very good.
Intubation.
Now, antiarrhythmic drugs, how do you classify them?
Vogan and Singh classification.
Class.
Vaughan Williams
Vaughan.
classification.
Sodium.
How many groups?
4 groups.
Classes.
4 groups.
4 classes. Class 1 is subdivided into 3. Okay. So this is
1A, 1B, 1C.
1A, 1B. Mechanism of action. This chart will tell you all about the sodium channel blockade, fast sodium channel blockade, slow sodium channel blockade. So first group of drugs are all sodium blockers, then beta blocker, then potassium channel blocker. Fourth group is calcium channel blocker. And of course, unknown mechanism, that's the fifth group like magnesium sulfate and digoxin, which are also used for antiarrhythmic property. And how do they affect that? What are all the side effects are all given in this. So you must know inside out. Usually they may give you amidrone and ask you which group it belongs to. It belongs to group 3 or class 3. Okay. So amidrone is one drug which will be available in ampule form and they can give you. And if they give you magnesium sulfate, they may ask you all about not only this antiarrhythmic property, but what are the other indications for usage of magnesium sulfate?
Bronchodilation, preeclampsia.
Bronchodilation, seizure prophylaxis.
Preeclampsia. You must first
Preeclampsia.
answer always should go for preeclampsia. Then only all other side. So lignocaine 1B class. Okay. Quinidine and propanamide 1A, and all the beta blockers 2 class 2. Right. Then you must know about vasodilators. Of course, sodium nitroprusside is not a common drug used in many things because of the unwanted side effects. What is the most important complication or side effect of sodium nitroprusside usage?
Cyanide
Cyanide poisoning or toxicity. Very good. Then NTG is a very common drug, so you must know what is the presentation, how many milligram in ml, how you dilute, how you give the dose, everything you should know. Similarly, potassium channel activators. Can you name one drug which is a potassium channel? Nicorandil. Calcium channel activators, you know, miscellaneous group of drugs. Like then antihypertensives, you should know about all about AC inhibitors, ARB, and then adrenergic neuron blockers. Do you know any drugs which are under the category of adrenergic neurons? Guanethidine. Clonidine centrally acting. Guanethidine is the adrenergic neuron blocker. Okay, centrally acting clonidine, dexmedetomidine. And CNS drugs, hypnotic, anxiolytics, anticonvulsants, and antidepressants. These are also some of the drugs which can be asked. Antiemetics. This is one category which may be very commonly asked, and especially 5-hydroxytryptamine antagonist. What is the common drug that we use under this category? Ondansetron, and the newer generation, phalanosetron.
Granisetron.
So there are so many other things. And you must know all about the mechanism of vomiting. Because we have discussed that in the earlier classes, there are multifarious apparent and different pathways. So always you use more than one drug to control emesis, post-op emesis. Single drug therapy is not very effective. So you always use, what is the combination that you use?
Dexamethasone plus ondansetron plus propofol.
Dexamethasone, ondansetron, and metoclopramide. Okay? These are the 3 drugs which are commonly used. And the other drugs acting on the GI tract, antacids. Which antacid do you have to know very well in pregnant patients?
Sodium citrate, sir.
0.3 molar sodium citrate. 0.3 molar sodium citrate. Okay. And H2 receptor antagonists. Are they used nowadays?
Yes.
What is the example?
sir.
What is the historeceptor antagonist we are using? Ranitidine. Okay?
Ranitidine.
Nowadays, ranitidine is not that frequently used because what is the cardiac problem with ranitidine?
Tachycardia and
Tachycardia, look more than
Renal.
that, it can produce junctional ectopics. Okay?
Yes,
The
sir.
most important abnormality it can produce is junctional ectopics. Okay? And then this mucosal protectors. What are the examples of mucosal protectors?
Sucralfate.
Sucralfate. Where do you use it?
ulcers,
GERD.
sir.
ICU patients to prevent stress ulcers. Okay, that is where the patients in ICU they are all very much stressed out. So it is better to give sucralfate to protect. What other drug can be used to protect the mucosa from the gastric erosion caused by NSAIDs? Prostaglandin analogs also can be given. Okay. So diuretics, you should know all about the diuretics which are used like potassium sparing, aldosterone antagonist, aspartic, the location where they act, which part of the nephron they act. Okay, and there are various side effects, everything that also can be asked. And the anti-diabetic drugs, you should know all about insulin, the various preparations of insulin. What are insulin analogs and what is their advantage?
So sulfonylureas.
Insulin analogs and
Insulin.
Rapid acting, short acting, and long acting.
Ultra short acting, short acting. Intermediate.
No. That's not. Insulin, I'm not asking about the classification of insulin. I'm asking about the group of drug called insulin analogs, which are very similar to the normal insulin that is produced in our body.
Insulin lispro.
Ah, so that is what very short acting and very, instead fast acting and shorter duration, so that the control of blood sugar is very easy. Okay, so that is how you use that. And sulfonylureas are oral drugs mainly. Biguanides are also oral. PP4 inhibitors, metyletinides. What is the complication of HGLT2?
Euglycemic ketosis.
Euglycemic ketosis.
Ketosis.
Okay, so if they give you anti-diabetic drugs, you should be ready to face questions on DKA, euglycemic ketosis, hyperosmolar acidosis. Okay, all these things you should be able to recall and answer. And corticosteroids, especially dexamethasone. What are the indications of dexamethasone?
Anti-inflammatory.
Anti-inflammatory,
Anti-emetic.
anti-emetic, and helps in analgesia also. Nowadays they have found out dexamethasone also can be used as a part of opioid-free analgesia. Okay, so it forms a component of opioid-free analgesia. So three indications for dexamethasone nowadays. One is anti-emetic, anti-inflammatory or reducing the edema, and the third is analgesic. And what are hormone preparations you should know? Commonly used hormone preparation. If you want to continue, if the patient is on that drug.
Progesterone.
Thyroxine. Okay, patients are hypothyroid patients. When they come for any surgery, you want to know whether they are taking any thyroid supplementation, and you have to give the drug on the day of surgery also. And similarly, patients who are taking long-term steroids like prednisolone, methylprednisolone, you should know when to stop or when to continue these drugs. So what are the indications for giving a supplementary dose of corticosteroids? What will happen if a patient is on long-term steroid therapy coming for surgery?
HPA.
Yeah.
HPA.
Suppression of adrenocortical axis. Okay, hypothalamo-adrenocortical axis suppression. Patient will go for hemodynamic instability. That is the answer that you have to give. Then you must know about oxytocin, indometrin, carboprost, which are all used in obstetric anesthesia after delivery of this. Now a few tidbit like questions. Now you are seeing this picture. Okay. How many of you are still using this or had an experience of using this? All of you had experience with this drug?
Yes, sir.
Have you all used?
Yes,
Yes,
sir.
sir.
Using only propofol.
Thiopentone.
You have used thiopentone. Okay.
Yes.
Now tell me, what is the drug shown here used for? Why is it marketed as a powder? You can see
It is
this.
alkaline in nature.
Huh?
It is
It is
alkaline in
unstable
nature.
in the solution.
It is alkaline in nature. What is this drug used for, first of all?
Induction agent.
Thiopentone is
sir.
the induction
It
agent.
was an intravenous induction agent
Induction
for
agent.
anesthesia. Okay. Any other indications or any other usage of this drug?
Sir,
For
in
electroconvulsive therapy.
seizures.
It can
So,
be
as
used
a
for controlling seizures. Okay. Then
seizures, barbital coma, pentobarbital coma.
barbiturate coma to protect the brain. Okay. Neuroprotection. These are the three indications you have to say. One is it regularly used the earlier days by intravenous induction agent. It can be used in acute epilepsy or a seizure activity due to local anesthetic agents or other causes if other drugs are not available. And it can be used as a intentionally as a IV infusion to reduce cerebral edema as well as reduce the oxygen requirement by the brain to protect the brain in hypoxic insults of the brain. Okay? And why it is marketed as a powder? That is the second part of the question.
Sir, solutions
Because-
are unstable.
Why it is unstable?
Sir,
Highly alkaline pH, sir.
It is a highly alkaline pH when
pH.
it is reconstituted into a solution. So, as I said earlier, alkaline pH drugs cannot stay in room temperature for more than 24 hours. They lose their potency. Okay, so it cannot be used for more than 24 hours. If you dissolve it, you have to use it in the same day. That is the reason why it is marketed as a powder. Now, the next question is, what are the contraindications for its use? In which conditions you should not?
Sharp.
Porphyria,
Porphyria.
latex
That's the absolute
astringentous,
contraindication. Other contraindications are more relevant.
state.
Now, the third question is, what is filled in the space above the powder and why?
The nitrogen, sir.
Nitrogen. Very good. Why it is
Because
filled with
now-
nitrogen?
Because normal air will contain carbon dioxide that will react with the
Very good. So that will cause kind of reaction and the potency of the drug will come down. Okay? And can this be loaded in the same syringe with dexamethasone?
No, sir.
Yeah. Why?
The pH, the acidic pH and alkaline pH, precipitation will occur.
So they will mix and precipitate. The drug will form a precipitate and block the needle. Okay. But if you continue to draw dexamethasone and this drug, after some time it will dissolve. Because the quantity of water is more, it will dissolve. But initially it will form a precipitate. Why intermediate causes pain on injection and how can it be avoided?
so it's actually preservative called propylene glycol which causes the pain.
Very good. How can
It
it
can
be
be avoided
avoided?
by giving lignocaine, by giving analgesic prior to the injection. Like
Okay. Any
lignocaine,
other alternate to lignocaine which can prevent this pain?
the fentanyl,
Not pentazone. Ondansetron. Ondansetron has been found to be very effective in preventing the injection pain of intermediate, which is due to propylene glycol, which causes damage to the vascular endothelium and produce the pain. What is the advantage of this drug?
it's a hemodynamically stable drug.
Hmm.
Does not affect the hemodynamic stability.
Main reason for this is lipuro preparation. This is for this, prevent the pain. Okay, so prevent the injection pain, they have made it as a lipuro. What is a lipuro? What other drugs are prepared as lipuro preparation? Apart from intermediate, is there any other drug which is painful on injection, which can also be prepared as a lipuro? Propofol.
Propofol and rocuronium, sir.
So this is a propofol lipuro also available. Okay, so intermediate glipro and propofol glipro. So how do glipro preparations reduce injection pain? The mechanism is
So it's a middle,
as an oil phase and allows
Oil phase.
larger proportion of propofol to be dissolved in it, thereby apparently reduces the pain. Okay. Now, some drugs can affect the urine color. So, which drugs can produce an orange color, blue color, red, purple, dark brown? Can you give examples?
Rifampicin orange urine.
Rifampicin orange, sir.
Rifampicin orange or red also sometimes. Blue or green?
Propofol green, sir.
Propofol as a infusion.
green on
Infusion.
infusions
Purple,
from more than 4
dark brown.
Red or pink, man. Chloramfenical dark brown, sir.
So
Red
these are all the
vancomycin.
things. For orange, warfarin can do that, rifampicin can do that, sulfasalazine can do that, nizopyridine can do that, some laxatives and certain chemotherapeutic drugs can always do that. And blue-green color can be by amitriptyline. What is amitriptyline?
Antidepressant.
Bicyclic antidepressants.
What is the mechanism by which they act?
It inhibits serotonin
SSRIs, serotonin reuptake
reuptake.
inhibitor. Okay, indomethacin, propofol, cimetidine, promethazine, methacarbamol, all these things, methylene blue, all these things can produce a blue or green color. Again, rifampicin can produce orange or red color or pink color, phenolphthalein and chlorpromazine, largactil, and thiazide. And phenolphthalein is one which can produce a purple color, and brown color can be by chloroquine, primaquine, they're all anti-malarials, metronidazole, ethylpentine, and all these drugs. And what are non-anesthetic uses of ketamine?
Ketamine is used as an opioid substitute or in opioid-induced hyperalgesia.
So very good.
In restless-leg
Environment usage, sir.
syndrome.
Analgesic in spine surgery.
No, that is
Antidepressants, sir.
antidepressant. This is the latest one. They have found out that,
Bronchospasm.
it is in ketamine expert anti-antihypertensive suited for opioid dependent patients, anti-shock and hemorrhagic and septic insults, anti-inflammatory effects, anti-tumor effects, brain and spinal cord protection, bronchodilation. These are all the non-anesthetic uses of ketamine. How is opioid tolerance and hyperalgesia caused? What is the mechanism? Where do people, which type of people will develop opioid tolerance and hyperalgesia?
Chronic intake.
Chronic users, especially terminally ill patients who are given large doses of opioid for pain relief, they are the ones who go into this problem. Okay, mainly. So the receptor desensitization
Of the receptors.
and another mechanism is called internalization of the receptor. So the opioid receptors become desensitized. They don't get stimulated by this drug anymore. And so that produces large tolerance. So you have to keep on increasing the dose. And another thing is these receptors. What type of receptors are there? Opioid receptors. What is there?
G protein coupled receptor.
G protein. Mu kappa and delta.
No, they are the varieties. What is? Which is a membrane receptor or
G protein.
internal?
G membrane.
What type of membrane receptor?
G protein coupled. G protein coupled.
G protein coupled receptor. Okay, very good. So it's a G protein coupled receptors, which is the membrane receptor. So that receptor will become desensitized initially. Then what happens? The whole receptor goes into the cytosol. What is called internalization from the cell membrane. So it cannot attract or get attached to the opioid at all. So what is the one which causes that? So changes in opioid receptor conformation caused by agonist-induced receptor phosphorylation, increased opioid receptor affinity for a substance called cytosolic B arrestins. Okay, this Interaction of B-arrestins with opioid receptor results in redistribution of opioid receptors from the plasma membrane to intracellular vesicles. This is called internalization. This process is called opioid receptor internalization. So the two mechanisms by which opioid tolerance and hyperalgesia are produced are one by first desensitization. Later on, the whole surface or the membrane receptor is brought inside the cytosol into vesicles called opioid receptor internalization. So beta arrestin is the drug which or I mean the component which causes this desensitizes cell to opioid by functional uncoupling of opioid receptors. Now coming to the last part of the discussion, why IV fluids are infused to patients?
To maintain
Maintain
volume
tissue
status and
perfusion.
electrolyte.
Tissue perfusion, yes, very good. Administer to maintain tissue perfusion and also maintain electrolyte concentrations. Or the third use is to infuse drugs, which can be used as a carrier. We many times dilute the drugs in 5% dextrose or normal saline and they use it as a carrier for infusing drugs. Why some drugs have to be given only by infusion, like your dopamine, dopamine, adrenaline, noradrenaline? Why we are giving them only as an infusion and not as a bolus dose?
It can cause tissue
Another
necrosis.
common question. Huh?
Noradrenaline can cause myocardial
They
necrosis.
are very rapidly metabolized. So if you give as a bolus dose, they will not have a persistent effect. So to have a consistent and persistent effect, it has to be infused and you must maintain the serum level. Otherwise, they will be broken down easily and the effect will wear off. Now, what are the characteristic and composition of various IV fluids?
Colloids and
They are classified as
colloids.
colloids and crystalloids.
Crystalloids.
And another classification of IV fluids is
Hypertonic, isotonic, and
based on their osmolality. You can say hypertonic, isotonic, or hypotonic positions. Any other classification? IV fluids used for maintenance. IV fluids used as a replacement. And IV fluids used in special situations. Can you give an example of IV fluid used for maintenance?
Injured
Well,
lactate and normal salines.
plasma light.
Yeah, these are the common things, you know. Then IV fluids used in special situations.
So in treating electrolyte diseases like hyponatremia, as a
Hypertonic saline, hypertonic
Glycemia,
glucose, all these things are called special situation drugs or fluids. Okay, then you must know everything about body fluid compartments and fluid balance physiology. If given an IV fluid bottle in your hand, you'll be ready to answer that. Of course, crystalloids, these are all the composition commonly used crystalloids: normal saline, trinyl lactate, acetate, plasmalate, dextrose 5%. These are the each one. What is the composition? And these are all the colloids. Hydroxyethyl starch 6%. And hydroxyethyl starch, is it recommended nowadays?
no, sir. Actually
No,
used as a
not recommended. Why? Because of the renal
endocrine.
complications. So, what are the disadvantages of using gelatin and dextran?
Anaphylaxis, sir.
Anaphylaxis, of course,
Anaphylaxis.
gelatin is anaphylaxis. And another important thing, blood grouping. They interfere with blood grouping. So if you want to do a blood grouping, you must first do that and then only start them on these drugs. Otherwise, they interfere with the Rouleau formation and give a false blood grouping report. Albumin, of course, is a natural colloid which is present, which is now recommended mostly as a replacement. And these are all the other varieties. Now, what are the side effects of intravenous fluids?
Overhydrate.
Abnormality, sir. Volume overload.
Nor
Volume.
with each and everything, there is an individual side effect. Or if you give too much of normal saline, it will result in hypochloremic acidosis. Like that, can you say other side effects? With the
Finger
various
lactate and lactic acidosis, sir.
hypokalemia and hyperkalemia can be caused by administration. Hydroxyethyl starch affects renal function, and some of them like hemostasis, that dextron 40 and dextron 80. In fact, they were regularly used by microsurgeons to prevent capillary thrombosis. But nowadays they are not recommended anymore. What is Farias-Lundquist effect? Anybody heard of that? Now that is effect is this in microcirculation, relative viscosity of the blood is lower than in larger vessels to facilitate more faster flow through the microcirculation. This is called, so the viscosity of blood in the capillaries will be much lower compared to the larger supplying vessels. It is called the Farias-Lundquist effect. What is endothelial glycocalyx? This is another common thing that can be asked if you are given a IV fluid bottle to assess your knowledge on the vasculature, anatomy, and how the fluids are retained inside the vascular compartment. So the glycocalyx resides on the surface of the vascular endothelium. It is projecting into the lumen of the vessel. Okay. Earlier we were thinking that there is only the endothelium is the first layer, then there is a media, then there is a outer layer. So that was the media which contains the smooth muscles. But nowadays they have found that there is a layer above the vascular endothelial layer projecting into the lumen, which consists of proteoglycans. It is made up of substances called proteoglycans, which are syndecan and receptor bound hyaluronan. These are the components that are making this. And the glycocalyx is negatively charged. Why it is negatively charged?
To repel
Repel what?
protein.
Platelets. Because platelet is the one which is the first to get added to the damaged endothelium. Okay. So in natural blood flow, this negative charge of the platelet will be repelled by the negative charge of the glycocalyx. Where else this mechanism is employed? Where negative charges repel each other?
Nephrons, sir.
Very good. Kidney, nephrons, excellent. The albumin is also negatively charged, and the podocytes epithelium also negatively charged, so they repel. That is why albumin is not coming into the urine. Okay, and glycocalyx plays a role in the mechanical transaction of shear stress in the endothelium and inhibition of leukocyte or platelet adhesion to the vascular wall. So this is another important role that they play. Now these are all the various other fluids which are that is balanced salt solution like plasma like A, normal salate, all these things, and their comparison with normal plasma with regard to the various electrolytes and the other components that are there, and the osmolality of all these things are compared. So you must know what is the osmolality, what is the fluoride, why plasma. Now what is the reason to introduce balanced salt IV fluids? Earlier we were using only a normal saline, ringer lactate, 5% dextrose, dextrose saline. These were the 4 fluids which were commonly used. But nowadays we are slowly switching over to balanced salt solutions like plasma light or normal salt, isolite, all these things. Why? Isoosmotic. This osmolarity and tonicity same. You say isoosmolar or isotonic, both are same or different?
With intact cell membrane it is.
Very good, excellent. The balanced crystalloids are mainly introduced to prevent excess chloride ions present in our normal saline. Because in normal saline, what is the amount of sodium and chloride? How many
150.
milliequivalents?
54.
Both are 154 milliequivalents, isn't it? Whereas the normal blood chloride level is only 95 to 105. So we don't want that much of excess chloride. As I showed you in the first slide, it will produce hyperchloremic acidosis, worsen the acidosis. So in order to replace that, this causes the acid-base imbalance. So that is the reason why they have come out with solutions which are so-called buffered crystalloids. Earlier it was bicarbonate containing solutions, but because they don't stay, they are not stable in the shelf. So the shelf life is very low. So they were replaced with anions like lactate, acetate, and gluconate, which are metabolized and excreted. So they don't cause any unnecessary reactions. Whereas bicarbonate will, what is the mode of elimination of bicarbonate? When do you administer bicarbonate? Correct acidosis, isn't it? So how does it get eliminated?
Renal.
Renal. Bicarbonate goes out by renal. NaHCO3. You inject sodium bicarbonate into a patient, what will happen? How is it getting eliminated? Which ion it will go and combine with? Is it a negatively charged ion or a positively charged ion, bicarbonate?
H plus
Negatively charged.
Negatively charged. So it will attract what? Hydrogen ions,
Proton.
which is positively proton. So HCO3 plus H, what will
Carbonic
happen?
acid.
It will become
Carbonic acid,
carbonic.
H2.
So it has to be eliminated as carbon dioxide. Okay. So it will form carbonic acid, which is unstable, which will be broken down into carbon dioxide and water, and carbon dioxide will be eliminated in the breath of the patient. So patients who are already having COPD, this will worsen the condition. And in patients who had a cardiac arrest and who have a hypoxemia, it will worsen the intracellular acidosis in the brain, because there it is very slowly excreted. So CO2 will enter the brain cells and worsen the condition. That is why earlier in the resuscitation of cardiac arrest patients, bicarbonate was a constant component. Intravenous bicarbonate was given, but later on it was completely removed. Okay. What are the characteristics of plasmalite 148, which is commonly used now? What is the other alternate name for this? It is also called as plasmalite A. Why it is called plasmalite A?
Acetate. Yes, acetate.
Because it contains acetate. Very good. So plasmalite 148 is calcium free, therefore compatible with blood and blood components. Number one, contains no antimicrobial agents. So if you use it, you must finish it up. You should not keep and then use it after 6 hours, 8 hours after cooking. And the caloric content is 66 kilojoules per liter or 66 kilocalories per liter and 16 kilocalories. pH of fuel is about almost like normal blood, 7.4. And it is supplied in Viaflex plastic containers produced from a uniquely formulated polyvinyl chloride. What are the contraindications or complications that can be produced by Viaflex container, this plastic bags? What precautions to be taken with Viaflex bag? It's a adaptable flexible bag. How does the fluid go inside when there is no venting in that bag? It is a collapsible bag. Okay. So it will collapse, and if you have seen the bag, it will stick to each other as the fluid gets drained. All these collapsible bags will stick to each other, and so if you are not careful, it will produce air embolism. And you cannot use pressure bags to increase the flow, just as you do in your other plastic bottles. And we should not use a open vented IV administration set for this. We should use only a closed IV administration set. Now comes the question, what is the term osmolarity and tonicity mean? Is there a difference or the same? You rightly said there should be. So osmolarity is the total concentration of diffusible and non-diffusible solids, whereas tonicity takes into account the total concentration of only non-diffusible solids. That is the difference between the two. What is compensatory reserve index with regard to blood volume?
After during induction, there will be some vasodilatation. We have to.
No guesswork. This question I mainly put it for Muttumani because he wanted recent advances. This is the latest advance. This is not in the textbook. This is from a recent journal. So the compensatory reserve index is a novel vital sign parameter. It is a newly introduced vital sign parameter using machine learning derived features of pulse arterial waveform or photoplethysmography. It is actually done by using your simple pulse oximeter probe, which can give a plethysmographic tracing, okay, to reflect real-time changes in intravascular volume. And the pulse arterial waveform is processed by an algorithm to calculate what is called the compensatory reserve index, which gives a value between 1 and 0, where 1 indicates normovolemia and 0 represents the point of decompensated shock, where systolic BP will be less than 80 millimeters of mercury. And this compensatory reserve index score was developed using simulated model of hypovolemia, and as a result able to detect early physiological changes that occur during compensatory phase of central volume loss and preceding changes in the conventional hemodynamic parameters like heart rate, BP, mean heart rate pressure, everything. And this also been shown to be individual specific because the algorithm has learned to identify individual variability to compensate for fluid loss. It is almost like using some sort of artificial intelligence for the management and the early identification of hypovolemia in the patient. Okay? So this is a novel vital sign parameter which is introduced using our simple pulse oximetry probe with a photoplethysmographic tracing, which is fed into the computer, which will calculate and tell you whether the patient is hypovolemic or going in for decompensation with only two easy values to remember. One which says patient is normovolemic, 0 which says patient is going in for decompensation. Okay. So that finishes all those questions on that. Okay. So any doubts or any questions on that?